It was the first group study ever done using psychedelics for cancer patients. What I was seeing in that study compelled me to leave my cancer career and focus on psychedelic research.
Well, Manish, hey, thank you so much for taking the time to have this conversation. Really appreciate it. I've been looking forward to this for quite some time. For the audience, Manish is the co-founder and CEO of Sunstone Therapies, a practice where he focuses and specializes in the research and delivery of psychedelic therapies. So, Manish, thank you so much for coming on the show.
Thanks, Brendan. Looking forward to speaking with you.
Maybe just to get us started here, if you could give us a quick kind of overview of your career and how you ended up doing this work, we'd love to hear that.
I actually wanted to study philosophy in college, and my father said, "I didn't come to this country for you to be a philosopher," and so I ended up becoming an engineer. Got bored with that, ended up going into medicine, and then in medicine went into oncology. But during my internal medicine fellowship, I did a fellowship in bioethics and got a master's in philosophy. A long-winded way to say, when I got into oncology, I did a fellowship at the NIH. I was on faculty there and did clinical research. And then left that and joined a large private practice and ran the research department there. And over my 18 years of practice, increasingly as an oncologist, I saw that I was able to take care of patients in terms of treating the tumor, shrinking it. But then a large part of the quality of life was determined by, emotional issues, psychosocial issues, I would say. And so, the things above the iceberg are like chemotherapy, radiation, surgery, but underneath it are the things that really determine how people live. And so I felt an increasing gnawing feeling of like, wow, I'm not really able to meet the needs of my patients. And that got me interested in psychedelics, as there were studies that were done at NYU and Hopkins initially that showed some promise in cancer patients. And that led me to write an investigator-initiated study using psilocybin for cancer patients. It was the first group study ever done using psychedelics for cancer patients. And so we purpose-built the space out and started the study and published that study last year in JAMA Oncology. But seeing what I was seeing in that study compelled me to leave my cancer career and focus on psychedelic research.
Yeah. And you've kind of just kind of dived right into that. So I was quite curious to hear about any specific challenges that you might have faced in kind of pivoting as an oncologist into this space.
Well, I've done a lot of research, and psychedelic-assisted therapy is really novel and a new way to do research. You're combining a drug, psilocybin, MDMA, there's various compounds, obviously, which alter a person's internal state in a profound and deep way, and they need psychological support. And so to build an infrastructure and care around that is quite complicated. It's closer to oncology than it is to most mental health conditions. Almost, when you go to a psychiatrist, they do an hour of therapy or prescribe medications and you go home. In psychedelic-assisted therapy, there's a preparation period, then there's a treatment with someone next to you, then there's follow-up integration, and that's closer to oncology in terms of, are you qualified, are you prepared, chemo education, then you get chemo, and there's follow-up. So this multidisciplinary is complicated, and this is all new, so the field is still learning how to do this. So I think that makes it challenging. And the other thing that's really challenging that I don't think people always appreciate is, in cancer and many other studies, we're studying something fairly objective. And so I can measure your tumor size. And here, it's really a subjective experience. And yet, how you feel, and yet we're asked to measure that and to quantify that and to treat that in our current paradigm. And so that can be challenging.
I can only imagine that after 18 years in, almost 18 years in oncology work, it must have been a little bit, I don't know, scary to kind of pivot and kind of create a new platform in this space. How did you think about that?
Yeah, so that's why I said a little bit about the college thing. It was, when we conducted the study that I wrote, and we treated, 10 or 12 people, and I was somewhat skeptical, honestly, about psychedelics and what they could do, but the profound shift I saw in a few patients made me realize, like, this is adult medicine, and this is different than what we currently do, and this needs to be studied. And so there came almost an existential moment of, I've had a very established career. I'm a well-known researcher, oncologist. 10 years, I can sort of think about retirement, and I'm going to leave and start something novel. But if I don't do this, I'm always going to wonder, what if, and I have something to contribute here. So in many ways, my experiences in medicine, engineering, and philosophy and oncology were preparing me for this task that I'm doing now. And so I could not do it.
And I'd love to actually just start to dive into the patient experience here a little bit. Since starting Sunstone, I know that there's been almost kind of like this renaissance of kind of research. How do you think about the landscape of research and options for patients today?
Since I've been doing it, the landscape has been shifting and changing. I think there was a lot of hype initially, and there was this promise, but the landscape is changing, and that it's maturing, that these drugs are not magic bullets. They're not safe for everyone. How do you really treat someone that's going to be helpful, minimize harm, is where we're really moving into, rather than sort of the hype and promise of them. And so, we've treated we just went through this. We've done over 200 treatments in the last 12 to 18 months with various psychedelics. We use a lot of different agents, 6 or 7 of them in all different indications. And so that experience is really allowing us to see that, wow, there's a lot more to learn here, and the field is just getting going on it.
How do you think about selecting almost between like options? I know that you're doing a bunch of research across a couple of different studies. Like, how do you think about the kind of various options that are on the table for an individual? I know that there's a few programs going for like treatment-resistant depression, a few programs going for MDD. How do you think about all that?
Yeah, so when we evaluate a person, we try to talk to them about studies that we have, but also standard of care treatments. And the first thing we're really trying to assess is for safety. And you're right. I think that it shares where things are right now in mental health in many ways. Just saw somebody today, and the question is, does a person have complex PTSD or treatment-resistant depression? And there can be a lot of overlap. And, I had a patient walk in and said, I had a psychiatrist told me that I have TRD, and another one told me I have PTSD. Which one do I have? And he had early childhood experiences that were difficult. He has feelings of depression. And so we really try to spend a lot of time sifting through what the underlying condition is, what the symptoms are. And then right now, because everything that we do is clinical research, see which study makes the most sense. Would they be eligible for, and would they be safe for? And try to navigate, is this the right time for that person? It's not that everyone should just go on psychedelics. It really has to be safe and an appropriate candidate for that.
Tell me a little bit more about safety. Of course, patient safety is priority number one. So how do you make that assessment?
Yeah, so there's the ones that people talk a lot about, such as medical safety. And so we look at things like blood pressures, EKGs, seizure disorders. There's psychiatric ones. Is there a personal history of psychosis, a family history of schizophrenia, brain mets? Those are the typical ones that we sort of look to make sure they're eligible. But then, another aspect that's not always talked about is it can be a very powerful experience. And someone has to be prepared to have that type of experience and have enough support around them while they go through it. And so if you just give it and the person doesn't have those things in place, or they're not prepared, it's not going to go well. In fact, if you'd ask me, well, what have you learned in some of the people that you've seen? Sometimes it's not the person that's depressed or suicidal that ends up, they're already living with suicide or thinking about it, and they actually do okay. Sometimes it's a person that just wants to take a drug and be fine, but not really deal with what might be underneath that's causing the depression. And sometimes things can surface that are difficult for patients. And if they're not wanting to deal with that, sort of the cat has come out of the bag, and what do they do with that?
That must be so hard to assess a priority. How How does one even go about that?
Yeah, so we do a fairly thorough clinical interview. We use scales, and we sort of know how to look for some of those pieces. And then if it looks like they're eligible, but there's some concerning, maybe there may be a concern, we proceed potentially, but then we talk to them about it. And then they have 2 or 3 preparation therapy sessions and see how they do with that. Are they able to connect with a therapist? Are they able to go inside? And then all the way up to dosing. And so if we feel like somebody's not making that progress, we'll say, like, this may not be safe for you, and we pull out. And so you're right. It's not just check the box and you enroll. It's not just a one-time assessment. It really is a team of the physician, the therapist, the research coordinator that's sort of assessing and making real-time decisions.
Yeah. And having seen research in a couple different settings across oncology and in this space, I'm curious to hear your take. What is uniquely difficult or different about doing research in this space versus the rest of the world of clinical research, maybe?
Yeah, I mean, so I hinted at one of them. One is the nature of subjective experiences. And so, in cancer, we reported nausea, tumor size, blood work, blood pressure, things that are really easy to measure. But here we're asked to report on adverse events of special interest. So one of them is like feeling grounded or feeling a sense of peace. So you have to report that. And is that these subjective feelings that people have, somehow you have to quantify them and report them. And that's trickier than something sort of purely objective. And then the other one, I think, that's really important in this treatment, almost unlike any other, is the drug plus the therapy. The drug plus the experience is the treatment. In oncology, of course, it matters, but then you want the right drug, the right chemotherapy, the right dosage. You want the doctor to be kind and you want the nurse to be good, but if you get the right, the tumor is going to shrink or not shrink. In this case, the drug may or may not work as well, depending on that other context. And that's much harder because, again, it's a human experience. So that's different than most other things in medicine where it's like the drug that's doing everything and there's not that as other element.
Yeah, this reminds me of conversation I had with Srini over at Atai, and I asked him what he would change if he could change anything, and he said it would be the size of the placebo response, or the kind of the nature of the placebo response in this space. As a trialist, on the ground working with patients, how do you think about that?
Well, I think that caring for someone is very powerful, and so I don't have an issue with the placebo response. I think that people coming in, they're feeling heard and seen, they do feel better. And if that works without psychedelics, that's great. So I don't have any issue as a researcher. I'm sort of thinking through that. And I think, to me, the placebo is more interesting in that it's not the sugar pill. It's that our minds are able to get better on their own with the right circumstances. So what is it about the mind that allows that? So the drug may facilitate it, but there's more going on. And to me, why placebos work are more interesting that they work. It tells you more about brain and mind than it does about placebo or psilocybin.
One of the things that I'd love to just spend a little bit of time on is stigma. Have you found this to be a challenge in working with patients in your practice? For
sure, some. It's a spectrum, so it's not one set of patients. I would say that there's a whole equally as challenging, I would say, is the hype. And so there's people that come in and they've read on the internet or watch something on Netflix and they want you to give them a treatment and have the big experience. And they have something very profound and deep, but it's not what they imagined it to be. And so some of it is really preparing for what the psychedelic experience can be, the heterogeneity of it, and it could be helpful in many different ways. And so having realistic expectations. On the other side, it's over-feared many times, and people say, well, does it make you go crazy? Or there's all these druggies. And so that's something we talk through as well. It's almost like I want people to forget what they know about psychedelics, both good or bad, and just come in with an open mind, look at the data and study it for itself. And so I think there is stigma, but it's decreasing for sure. I mean, I have lots of people that are very interested in psychedelic-assisted therapy studies because their current treatments are not working. So even in the last 5 years, the stigma is, increasing really quite steadily.
Yeah. One thing you said reminded me about the conversation we were just having before we started recording here, which was around showing the data and maybe this idea of like agency amongst patients. How do you think about providing the data in a way that is accessible and appropriate for kind of the for the individuals who are kind of considering the research?
We talk about the studies that have been done. We talk about there's a risk. There's a physical risk of nausea, some of the symptoms they have. We talk about risk of psychoses, potentially dissociation or becoming unstable. Sometimes there's an increased risk of suicide. All these are relatively small, but we sort of talk about all of those pieces. It's just like in oncology or anything else. We talk about the potential risk and the benefits of that.
Yeah, I guess maybe one of the things that I'm kind of curious about is priming, right? Like some of the kind of early studies are so positive that like are you worried at all about like potentially priming or over priming the individuals?
I guess in theory, yes, but the people that we see are really quite complicated. I mean, they have had depression or trauma for 18, 20 years. They've been on multiple medications, have tried lots of different therapies. And, if it's as simple as like telling them something's going to work and getting ready and it works, like it just isn't, it's quite when it works, it's quite a deep, profound experience for people. It's not, I don't think you can prime your way there. I mean, as a physician, I've been in practice for 20 years. I've used lots of interventions. There's something happening here when it happens for somebody. It doesn't happen for everybody. It's not a magic bullet, but it's not as simply explained away as that.
You must have seen so many profound patient experiences, lives changed. Maybe kind of help us take a peek behind the curtain here. What do some of those stories look like?
Yeah, so, I can tell you, I'll share a cancer patient. So she had advanced cancer and she was on psilocybin, had a very difficult experience. Like it was challenging. She felt like she was facing her death, felt like she was going to die in the session. She knew she wasn't dying, but that's what it felt like. And so she got through it. And then she came back, a week later and she said, I had this really profound experience 2 days later. It was in the late fall, like November, this time of year when she went, and she was at the lake and she said, I had this sense of peace come over me. And I said, what happened? And she said, well, sun was setting and all these crickets were super loud. And then all of a sudden I got the sense of peace. And what I realized was come winter, all these crickets are going to die. And in the spring, there'll be a whole crop of new crickets. And in the same way, I was born, there were all these humans that have died over my lifetime. And there'll be new ones as I go on. And for her, it was this connection of like, this is not personal to me. This is like the nature of life. And I'm just part of all of that. And so it's one thing to say it and to even intellectually get it, but for her to feel it in some, deep cellular level where it's like, wow, this is something larger that's going on. It really helped her sort of get some acceptance around that. Another person, I would say, he was on a study for trauma, and I had given him his drug, and then you come in later to give a booster. And when I came in, he said he did not want the booster, and I said, "That's fine. Can I ask why? What's going on?" He said, "Well, I'm in so much pain. I don't want to take a drug that's going to make it last longer." And I said, "What do you mean?" And he said, "Well, I realized my mother hated me. And I don't want to take something that's going to make me feel that even more." And what we got to talk about was that he's been aware of this feeling his whole life. It's not something that's new. It's coming into his awareness. And this feeling that I'm bad and that's why she didn't love me is now something he's lived with that's affected all his relationships. And that's a core belief he had. And starting to work with that to say, wait a minute, I'm not necessarily bad. She may not have liked me. That doesn't make me bad. And that feeling of me being bad that's carried him throughout his life has affected him. And that became to start to shift that for him. So those are two stories. And other people have had the typical sort of mystical like experience where they feel this oneness, this unity, and just this profound peace. And for them, it's really powerful because they've felt depressed for so long. They've never felt that feeling as they can remember. And that in itself, knowing that it's capable and they've felt that, is something they can go back to and has been helpful for them. So, I'd say there's not a typical psychedelic experience. It's a heterogeneous experience, and it helps some people in different ways.
One of the things you said earlier was that there's no silver bullet. It is such a heterogeneous experience. Have you noticed anything, any hypotheses as to like when or for whom these experiences really make a difference?
So when I say it's not a magic bullet, I don't think it's that for many people you don't take one and it's sort of done, but you begin to sort of crack the ice. You start beginning to do work that gets access to these things that you need to change. So that person I told you about, he learned this at a very, very young age, like pre-verbal almost. And so, if you're a young age, you might say like, chair, door, and you say it bad, chair, door, bad. But you learn that you're learning language. And so as an adult, someone can tell you in therapy, a chair, but you're not bad. And you can say that, but you do not feel that. But I think in that experience, it allows you to start saying, I tell people it's like Prince, how you said, I'm the artist formerly known as Prince. You start saying, I'm the person formerly known as bad. And so from bad to the person formerly is bad to then I'm actually good. And that might take a year or two. It doesn't, but entering into that area where you can access that and maybe reshape that belief is what psychedelics open up. But the work isn't usually done at that moment. So I think people that want a one and done and want an instant fix, it doesn't work for as well. The ones that are willing to work at it and let it become another tool along with the journeys on, I've seen that to be the most profound help.
Let's call it like a lot of the sponsors that are doing work in this space will assert that, actually they're trying to actually isolate the drug effect from that, like the kind of ongoing relationship and the kind of therapist experience. But it sounds like to you like that's been impractical. Like might I say? Like how do you think about that?
Yeah, I think it's a limit that we have currently in medicine. It's like we understand drug and we have boxes that fit into that. I give you this happens, you get better. And this is more complicated. I do think that it doesn't have to be as complicated as people make it. I do think the ongoing therapy is important, but there are basic safety parameters that are needed for preparing somebody, dosing and treatment. And that's like a clinic. It's the practice of medicine. It's like, how do you, in cancer, we gave cisplatin-based chemotherapy for testicular cancer and it was curative, but people were sick and they would throw up and then in the hospital for 5 days. And now it's all outpatient because we learned how to give the right antiemetics, the fluids, the sequencing, and that evolved from the practice of it. Doesn't make that go away, but it's not like it's, all of it up front. And so I don't think that all has to get defined by the pharma companies. Ultimately, it'll be the sites that are doing the practice that will be able to help establish the standards of care.
Yeah, I'd love to start talking a little bit more about the site experience and potentially even the kind of foreshadowing to the potential provider experience. What are some of the unique challenges of running a site that's entirely focused on this space?
So in terms of studies, one of the challenges, the studies are pretty restrictive. And so there's lots of people that are not eligible. And so there's a lot of interest in then having to disqualify people can be a challenge. And so you have to screen a fair number to figure out who it makes sense for. It's a challenge because this is novel therapy and treatment. So a lot of times the person undergoing the treatment doesn't understand, the family member, or even the providing therapy, the providing network. And so there's a lot of education, a lot of effort that's needed. And then just logistically and operationally, it's quite complicated. For one treatment, there's 20 appointments between the screening and the rater assessments and the blood work and the EKG and the therapy and the dosing. And so it's a coordination between the whole team and that person, that schedule, that's one person for one study. But if you have 10 patients on 5 studies, that really gets to be an infrastructure and an operational challenge. And that's a lot of times underappreciated.
One of the things that, seems to be let's call it a competitive frontier is the length of the experience, the kind of, as a result, the burden on the kind of care team. How are you starting to see things shake out as you think about, knock on wood, a few of these get approved? How are you thinking about like the kind of delivery setting evolving?
Yeah, we think a lot about that. And so one of the things is that the therapy team that's providing that, you can't do this treatment. A therapist can't treat someone every day for 5 days. It's way too draining. It's too much. And so we usually limit them to no more than 2 treatments a week, usually about 6 treatments a month. And then they need a lot of support in terms of processing what happened, giving time to think about it. So we provide supervision, we provide a lot of training. And so the care of the team is going to be really important in providing this care. And so, yes, it is like, it's not like sort of light treatment. It's intense. It's like surgery in your brain, except for surgery in your soul. And so, but it's intense and it can be profound, which is different than sort of little drips and drabs.
It sounds like for the therapists, you're kind of limiting the number of sessions that they also do in a week.
That's right. That's exactly
how did that practice come to be? I haven't heard much about that before.
To treat one person in 1 week, you do 2 hours of preparation. The treatment is 8 hours. The follow-up is 2 hours. So that's in itself 12 hours. And after that, man, the person is exhausted. They're not sort of ready to just pick right back up. And so we saw that. And then if it's not as intensive a treatment, they could maybe do another treatment, sort of the back half of the week, but they would never do it back to back. And so just in practice, seeing it and talking to a therapist and being in relation with them, we realize what they need for self-care and how to provide that. Because if they're not in a good place, they're not going to be able to provide really good care to the patient, and the therapy won't work.
How much more attractive does that make, some of these DMT or 5-MeO DMT programs in your mind?
Because they're shorter acting?
Yeah.
I think time will tell. I think at the end of the day, if something works, is what people are going to go after. And so, some of the ones that we work with DMT, we've worked with psilocybin, and for someone that has been stuck for 5, 8, 10, 20 years, it's not that much time to really shift in a meaningful way. And so they've spent hours and hours in therapy or on medications for years with like minimal to incremental benefit. And so, so at the end of the day, whether it's 4 hours or 8 hours of treatment, it's really whether it works or not.
I can totally see it from a patient perspective, the kind of difference being marginal, but from a provider perspective, the difference being significant. Is that how you see it, or maybe not?
Yeah, potentially. I certainly think from a pharma or insurance or reimbursement perspective, it would be better. The best scenario is you could use this and not need any therapy at all. Right? It makes it easier. Then less therapy and less drug and less time is even better. And so is it wishful thinking, or is it like, so to me, it's like what works. It's going to be more, it is more of a burden or a cost on a site if the treatment takes 8 hours rather than 4 hours. But for me, yes, that's true, but I don't want to wish that into existence because that's what I wanted to happen because it's easier for me. At the end of the day, it has to work.
Yeah. Yeah. The pragmatic provider and you I've heard is, hey, what matters is that it works first and foremost.
Yeah. And so I hear lots of these debates, and sometimes I just think it's what you want. You'd love for it to be short. You don't need anybody in the room. Great. That works, and it's easy, and it's delivered. Everybody understands that paradigm, but reality always wins.
Yeah. I'm curious. Have you encountered yet individuals who have had a response to one, but not another. And the reason I ask is because as we think about, maybe the commercial future of some of these options, I'm curious, like, do you see a world where people have to, be trying a few of these to find the one that really works for them? Or am I not thinking about that right?
No, I think that's right. I think that, or it maybe just be more personalized. I think we're getting better and better about thinking about where the person is in their life story and what they might need. And so there are some psychedelics that are being developed that are shorter acting and lighter. And that may be sufficient for many people to get things moving. And they may be ready for a deeper, bigger experience, or they may not need that. For someone else, they might need that to sort of, if they've been really stuck, to get that moving and then come back. And so I think we think a lot about, for a person that comes in, what's the right thing they need before then? Is it more therapy? Is it learning mindfulness? What are the other aspects? And then where do psychedelics fit into that, and which psychedelic? And then, to me, we're not there yet, but it would be to make a personalized, tailor-made approach for that person, because each biography is somewhat different, and we're still really learning that.
Yeah, it's so interesting, this idea of like, right now we're in a phase where dose control is so important, but it sounds like from the healthcare provider's perspective, it's actually kind of like a variable equation that you need to solve.
Yeah, right now it's one size fits all. It's like one dose, one drug for this thing, and you put everybody in it, and it's going to work in that percentage. But it's just not going to end up being like that in the long run.
Fascinating. That'll be really interesting to watch as things progress.
Yeah.
I'm curious. You see the whole world here. What are some of the exciting programs you're kind of particularly interested in, or particularly watching closely right now?
So we do, commercially sponsored studies, but we also do our own IITs. And I'm really interested in some of the things that we've been doing in terms of the group. So for one of our studies, we treat 4 people simultaneously. So they do a group preparation together, and then they come in at the same time, all take psilocybin at the same time in separate rooms. But then the next day they come back for integration. They talk about their experience together. And what's been really exciting for me is to see the connection that people form and how long that lasts. And so this study ends in 8 weeks. The first study we did ended at 8 weeks, but that group is still meeting 3 years later, once a month. And so from that trial, so not everyone goes, but we have, and it was because they asked for it, that the trial ended, and one of the participants said, I can't stop meeting. You guys have to put something together. And so the trial ended, but we opened up a monthly group that one of our therapists leads. And then if you've been on our study, you could go on it. And that's been going on for 3 years. And so I think there's something really powerful in the group approach done correctly. Another study that we're doing is with a cancer patient and a family member, both getting MDMA together to see how the cancer has affected their relationship. And again, that's very exciting to me to see changing the dynamics and the culture of a person, how much that affects it. And so those kind of things are really interesting to me. And then, I would like to see more different dosages because I don't always think, sometimes I think less is more. And so what is this supposed to look like? Right now we are in this phase of, let's get these drugs over the line. This is the standard. And I totally agree with that. We do have to do that work, but really starting to look at what is happening. What is the role of therapy? How do you best design something for a person is what excites me.
Yeah. And maybe this is a good kind of dovetail into the future here. How do you envision kind of the integration of some of these therapies into mainstream healthcare, mainstream psychiatric care over the next, let's call it 5-10 years?
Yeah, I think, and I think it has to be integrated into that. It can't be isolated on its own entity. And so I see it as a continuum that people will come in, they'll be evaluated. They might need an SSRI, they might need therapy. And then knowing this is another tool in the toolkit. And after they've had this experience, they're able to continue on. And so I think designing a program and a path for a person that's individualized to them is, I think, where it's going. And And so not everything has to be recreated. Some of those things work. We find a lot that after people have gone through psychedelic experience, things that didn't work as well before seem to be a lot more effective, like yoga or mindfulness, um, or group therapy, or just therapy in general. They just have unearthed so much material that now therapy is much more effective. And so that to me is very interesting, is the intersection between what's already available and how that fits into to support this work and how this can support other ongoing tools.
What do you think it would take for psychedelics to be kind of first line option instead of like SSRIs?
I don't know that they should be first line options for everyone. I think it really depends on the person again. And I think we need to understand better safety, who it's not right for. I think we need to make sure that we have the systems in place to provide that support, not just sort of take a psychedelic and go home. And so those things would make me more comfortable with making it first line. But I think, so if someone has been doing relatively well and they have a bout of depression, I don't think the first thing they should do is do a psychedelic.
Sounds like you're triangulating in on, this is actually best for more severe cases, more serious cases.
I wouldn't even say necessarily more severe. I think for some people that have had a serious event or they're depressed and they're you want it to become chronic. And for those people, it could be. But I think identifying that is really important. And so we are treating a lot more severe, but I don't know that the first time someone has experienced grief, they should just go straight to a psychedelic. Maybe, but I would want them to, if they've done no therapy and have done not able to be with their inner experience, and on a psychedelic, what you really notice is your inner experience, they're not going to get as much out of it. So, during a psychedelic experience, you have eye shades and music on, and it's a very internal experience. And the main thing you're doing is noticing what's going on inside of you. And so if you're not able to do that at all, not on a psychedelic, and not curious about that, psychedelics probably won't be harmful, but it probably won't be as helpful as it could be if we don't do other things first.
There's kind of a debate, I think, going around of whether it's the kind of experience, the neuroplasticity, or both together that matter. Curious where you sit in this in this debate.
I guess I don't see so I think that in the psychedelic experience, you're able to access parts of your mind. I think that's the remarkable things about our brain, that they can be remade, and that things that you held deeply as profound truths can be questioned about yourself and the world that shaped you. And so that's the neuroplasticity, because you may have formed those at a very young age. But what allows that to happen is a safe environment, and that's the experience piece. And so I don't know that I see that as separate. What allows neuroplasticity is a safe, supportive environment that understands the experience that you're having. I don't think you can have one without the other.
Well, Manish, hey, I've so enjoyed this conversation. Maybe last kind of closing question for you here is, if you could wave a magic wand and change anything about how psychedelic research is being done today, what would you change?
I think one of the hardest things has been as a site is I don't always think the sponsors, the regulators, or people out understand how hard it is for patients that are looking for this treatment. And the studies are well written, and they can be really restrictive. And for many people, they're coming and this is one of their last hopes. And for them, disqualified can be really difficult. And I would want us to really think about designing studies to both answer the scientific question, but also patient care in mind. And sometimes I think they're done in a vacuum, or can be conceived of this is what's the best design study. But these are actual human beings that are going through this, and how does this impact them? And I would like more consideration placed on that.
Okay, so I got to ask the follow-up question. Are there a few offending criteria that you'd most like to see rethought?
Yeah, so one of the ones is so you come in for the study and you're screened to be eligible, and we do what's called a MADRS to assess your depression. And then you begin therapy. And then the day before treatment, we do another assessment of the MADRS. And if your depression is improved, then they cancel it and you can go on to your psilocybin. And that is really upsetting for a participant. And the rationale is, well, the depression is better, maybe they don't need it. But sometimes is that they're looking forward to their session next week and they've seen some progress and they're really hopeful, and then they don't get their treatment and they're devastated and their depression comes back again. So that's something that's really, I don't think, always well thought out. And then I think sometimes on paper the diagnoses are black and white, but in real life it's not like that, and so it's they're really borderline. That's mental health. It's our mind. It's not, again, like your tumor is 3 centimeters. It's like, you have depression, and when it's treatment resistant, it has to be this number of treatments that have to be failed for this long. So if you were on it for 5 weeks and it failed, it doesn't count because you weren't on it for an adequate duration. But 6 weeks would have counted. Is that really a different person or not? And so I think it's not always based in real clinical world. And so those are sort of the things that, and that's hard for people because they don't understand why they aren't eligible. And so we feel that a lot at the site level.
Yeah. Have you seen any, gosh, I know that was my last question, but I'm just too curious to keep going here. What have you seen that has been, I guess, effective or productive to kind of solve for these kinds of scenarios? I've got, I know a lot of the people that are sponsoring the study, so we have good conversations with them and trying to have these types of, I think it's going to be slow. I think mental health is generally poorly misunderstood. And so it's raising awareness. I think patients advocating for themselves. I think us raising these issues is going to be part of the progress. And then, a challenge is like, do you really need to have this criteria, or is this just sort of a nice to have? But I think the work that you're doing, raising awareness, I think galvanizing people. At the end of the day, I think the agency needs to go back to the patient and the patient groups and have their voice heard. And their needs addressed. And I think that will change how some of this happens. Yeah, absolutely. Well, powerful stuff, Manish. Again, thanks for taking the time to have this conversation. Yeah, it was great talking to you, Brendan. Likewise.